let's discuss epiglottitis, also known as supraglottitis. It is an acute inflammation of the supraglottic region of the oropharynx, inflammation and edema of the epiglottis and of the vallecular arytenoids and the air epiglottic folds. So you've got several anatomical structures that are affected. Unfortunately, too often than not, there can be sudden airway obstruction and death, and that can be involved in our exam. So let's look at this closely. Epiglottitis most commonly caused by bacterial infection, but it can be caused by viral or a thermal injury. It is considered rare, but it's life-threatening. It occurs most often in children. The causative agent is Haemophilus influenza. But that has decreased related to the vaccine. The other causes that we know for epiglottitis involve A, B, and C streptococci, Streptococcus pneumoniae, Klebsiella pneumoniae, Candida albicans, Staphylococcus aureus, and Neisseria meningitis, also varicella zoster virus and other viral pathogens. So there's many causative agents. So there has been a steady increase in adults, about 2.5 times greater than in children. So right now we see about 1.9 out of 100,000 adults being affected. There is, it does have a predominance for males versus females. The median age, or the mean age, is around 45. It's a lot higher mortality in adults, about 67%, versus the mortality in children, which is less than 1%. Pathophysiologically, again, caused by a variety of organisms, refer to 403. Children, it's still under 5, it's still Haemophilus influenza. And then patients with underlying disease, you're going to see Aspergillus, Klebsiella, and Candida being more of a factor for epiglottitis. And what was interesting for me, and I learned a lot reading this chapter again, was those non-infectious causes, like the thermal injuries with crack cocaine and marijuana smoking. Remember on the news last year that talked about the adolescents and young adults that were swallowing those dish detergents, those automatic dish detergent packets? That's been known to cause epiglottitis. Chemotherapy of the head and neck, trauma from foreign objects, and burns associated with bottle-fed babies, those parents putting those formula in microwaves and then feeding it to a baby. Clinical presentation is usually acute onset of severe throat pain and difficulty swallowing, fever, shortness of breath with sitting up and leaning forward in an effort to enhance airflow. So you actually see your patient take that posturing. They're drooling because they're unable to swallow their saliva. They have anterior neck tenderness, lymphadenopathy, a cough, stridor, respiratory distress, and hoarseness. And in children, you're going to see shortness of breath and stridor. That pain with swallowing and the sore throat and difficulty swallowing and voice change is so predominant in adults. The typical patient comes for assessment in 8 hours up to 4 days. So just depending on the intensity of the symptoms. Physical exam findings. I put this because it's interesting. They might have a fever or may not. They might appear very toxic looking or not. It just really depends on the severity of infection or the cause of the inflammation. Adults' anterior neck is tender, sore throat, severe sore throat. So you get those two, you consider epiglottitis in your differentials. If respiratory distress and they have that tripod posturing, sitting upright, leaning forward, unable to swallow their secretions, those are all signs of epiglottitis. And here's the caution. If you use a tongue depressor to assess the pharynx, you may provoke laryngospasm in the patient with epiglottitis. So you must know before the exam what are the presenting symptoms, okay? Because you do not want to create airway obstruction. The gold standard diagnostically is to visualize with a laryngoscope. Sonography is accurate, but not seen as often as with the direct laryngoscope, especially that fiber optic nasopharyngeal scopes. A lateral neck film is kind of old school. You'll still see it being done, but it's not really a true diagnostic tool. I did include the thumb sign in the last slide for you to look at. CTs, MRIs are not generally ordered because of the time and just the positioning of the patient. CBC with diff and arterial blood gases can be helpful. Management and treatment. So epiglottitis is a hospitalization, okay, because it is that patient's considered to have an unstable airway. You're going to let them sit upright with humidified oxygen, close observation with airway management, antibiotics and steroids, usually IV. ICU is necessary for aggressive airway monitoring. And what we do is an immediate consultation to a specialist, to that otolaryngologist if they're available. And you anticipate those that patient's going to receive IV broad spectrum antibiotics. Patient education, again, explaining all procedures and addressing any thermal causes with the patient when appropriate. Of course, not during the acute phase, but you have got to address the risk factors, and then really promoting age-appropriate vaccinations so that it is not a vaccine-preventable organism that caused the infection. Look at the X-ray on your right. It's a pediatric X-ray out of UVA. They've marked it very well for you to look at that enlarged tonsil, the adenoids, and the fold thickening, and look at that thumb side right there. Again, it's not a diagnostic tool per se, but it is something we've been using for years as an indication and a confirmation. Thank you.